Slavic, and I'll be talking about muscular dystrophy today. So, muscular dystrophy is a group of genetic diseases or characterized by progressive skeletal muscle weakness and muscle cell death. It's often diagnosed in young children around ages 1 to 5, and they're typically male, which I'll explain later. So dystrophin deficiency is one of the root causes of muscular dystrophy. Dystrophin is one of the largest genes known in the gene code. It's also known as the DMD gene. So it's a protein, and in normal skeletal muscle tissue, it contains very small amounts of dystrophin, so like 0.002% of total muscle protein, so very small, but its absence is significant enough to create complications in the intercellular pathways, which leads to myofibril necrosis, muscle weakness, and fatigue. So the role of dystrophin is it's part of a group of proteins, a protein complex that works together to strengthen muscle fibers, protect those muscle fibers, contract, and relax the muscle. So it's very involved in the whole muscle complex. So the dystrophin complex itself acts as an anchor connecting the muscle cell structure framework, so the cytoskeleton, to the lattice of the proteins and other molecules outside of the cells, so the extracellular matrix. So the complex also plays a role in cell signaling by interacting with proteins that send and receive chemical signals. So this protein is extremely important in the activation, contraction, receiving and sending signals to and from the muscle. So a lack of this protein creates extreme complications. So I actually found a biopsy section of immunolabeling for dystrophin, which I found that was kind of cool. So they stained dystrophin antibody staining on a biopsy of muscle cells. So in biopsy A, the dark lines surrounding the sarcolemma are the dystrophin antibodies. So it indicates that dystrophin is present, which is what you would expect in a normal biopsy of skeletal muscle. And then in biopsy B, we have a 4-year-old boy with DMD with no detectable dystrophin. So there's barely any staining present. So that indicates that the child has a lack of dystrophin, so the child probably has muscular dystrophy. So this was just a nice photographic representation of the lack of dystrophin in the disease. So then the genetics of muscular dystrophy. So an overview in genetics. The male has one X chromosome and only one Y chromosome, while the female has two X chromosomes. So muscular dystrophy is linked with the X chromosome only. So this is why males are much more likely to be affected by the disease. So only one altered gene is necessary for the expression of the disorder. And since males only have one X chromosome, if they have a mutated gene with the muscular dystrophy, they are stuck expressing that gene. So with this, females can be a carrier since they have two X chromosomes, and they can pass on the gene. So this is why generally females don't express any signs or symptoms of the disorder. So I included another picture of the progression of the disorder. So again, onset is 1 to 5 years old. And you can see here the lifespan of someone with muscular dystrophy is very premature. So usually after 20 to 30 years, the person will pass away. So you have the development delay, trouble standing, progressive ambulatory changes, so trouble walking, which leads to the need of a wheelchair, And then eventually the skeletal muscle will not only be deformed and necrotic, but heart muscle tissue will also atrophy. So this leads to problem with like respiratory problems and breathing. So the person may need to go on a ventilator and be on round the clock care. So symptoms of muscular dystrophy are Gower's sign, waddling gait, foot drop, and contractures. So Gower's sign, I have a picture right here. It is one of the first signs with young children that you can basically tell that the child has muscular dystrophy or some form of it. So the child isn't able to pick themselves up, so they have to kind of hoist themselves and push off with their hands and work their way up their legs to stand up straight. So this is because there is severe weakness in the pelvic girdle and the gluteal muscles. They're not able to extend their back. So they have to compensate by working their way up with their hands onto their knees and thighs and straight up. And this is also because of this severe weakness in the pelvis and back, you also see what's called waddling gait. So the child's pelvic girdle is so weak that they are not able to stabilize their pelvis. So when they walk, they kind of sway from side to side in a waddling motion. So I also have that kind of highlighted in the second picture. What also is common is a foot drop due to poor ankle flexion. So the child has poor ankle mobility, or ankle strength, so they are not able to pick their foot up. So it kind of creates a dragging foot, which is foot drop. And then for contractures, contractures is a permanent shortening of the muscle or joints, and it limits range of motion. So again, this is another way of hindering that range of motion and those joint mobility. So the child really doesn't have good joint mobility throughout the major joints of their body. So the shoulders, the pelvis, the knee, and the ankle. So diagnosis is progressive symmetrical muscle weakness. So throughout the body, you see the joint contractures, and then you can also do a muscle biopsy, like I showed in a previous slide with dystrophin staining. Genetic testing, so deletion or duplication, so you can look for that DMD gene in the genetic code and see if it's present. And then lastly, a more invasive screening or diagnostic is creatine kinase blood levels. So normally in healthy skeletal tissue, you'll have high concentrations of creatine kinase in the muscle cells of the body. During or when an individual has muscular dystrophy, the muscle breakdown also breaks down the contents in the muscle cell itself. So the contents in the muscle cell enter the bloodstream, resulting in elevated levels of the creatine kinase in the blood. So those are a few invasive, non-invasive ways of diagnosing someone with muscular dystrophy. A few complications to consider before prescription are the contractures of the hip flexors and plantar flexors, which will interfere with ambulation. So again, walking, those contractures are just really hindering the range of motion. This also ties in with scoliosis because it's also common with patients with muscular dystrophy. It can actually get pretty nasty if it progresses to the thoracic cavity because it will complicate respiration. And it's important to keep that in mind when you're incorporating exercise in someone's life. So, and then another factor is if a child becomes wheelchair dependent, they can also be at risk for becoming obese. So, since the child is bound to a wheelchair, they are no longer expending as much energy as they once were. So, if they continue with the same nutrition and diet as they had before, it could lead to slight weight gain. So, that's just something else to keep in mind. So management and medication, there is no cure for muscular dystrophy, unfortunately. So management is the main focus. So we are focused on maintenance and function. So exercise can help improve the maintenance of strength to perform daily activities, reduce progression of contractures, and decrease the formation of scoliosis. The only medications that I could find to reduce strength loss are corticosteroids of prednisone and deflazacort. So they increase strength by 4 to 6%, so by not too much. And they also come with a lot of negative side effects, loss in bone mass, increased body fat, insulin resistance, and increased BP. So depending on the severity of the disease, your healthcare professional or doctor may or may not prescribe these or think that they are going to be beneficial. So for my case study, I had a 6-year-old male with the risk stratifications of difficulty getting up from the sitting position or laying down, so that Gower's gait. So and then also waddling gait. And then for the risk group, he has the progression of Duchenne muscular dystrophy. So that is one of the most common categories of muscular dystrophy. The goal here is to maintain muscle tone for as long as possible and reduce the disuse atrophy. So special considerations is exercise is possible for those with DMD, but we want to avoid intense exercises such as powerlifting and HIIT training, because again, we are not trying to build muscle here. We are just trying to maintain the strength that the individual already has. So any powerlifting or HIIT training, any intensive exercises is not really necessary, especially since the child is so young. So for exercise testing, I would have chosen aerobic. So for aerobic fitness, I would have done a 6-minute walk test. Since it's one of the only aerobic fitness tests that is proven not to harm patients, I figured it was the best pick. And then for flexibility, I would go with joint mobility. So I would get the gynecometer and get measurements for knee extension, ankle dorsiflexion, shoulder abduction, and elbow and waist extension. And then the Romberg balance test. And then for muscle strength, I would go about using motor faction measurements. So this is meant to replace the 1-rep max testing that we would use for a typical healthy client. So it's modified hip extension, knee extension, ankle dorsiflexion, shoulder abduction, elbow and wrist extension. And then obviously we would gather weight and height for his BMI, just to have that on record. So as we progress through training, as the child grows, obviously height and weight will need to be monitored. So for exercise prescription, I would have the child doing 30 minutes a day, 5 days a week for 24 weeks of this specific prescription, and then retest in 24 weeks to see if the muscle atrophy has slowed down, because that's the main goal here. So for 15 minutes, first of arm cycling or using a water wheel, and then 15 minutes of leg cycling. So in terms of the speed, I had 700 to 1,000 revolutions for both arms and legs. So just an idea, just something to gauge the intensity. So the intensity level should be at a point where the child is engaged. Again, because this is a 6-year-old child, and performing the exercise at a low constant speed. So we want to avoid any discomfort or extreme fatigue, because the whole point here again is maintenance. So we don't want to be pushing the child where they're uncomfortable. So for my conclusion, when I was looking up the disease, I had a lot of trouble finding some like conclusive research on the benefits of exercise with